endometriosis is such a big thing that we need to diagnose it very well and plan surgery very well. And for us to be able to do, if this woman is doing the surgery for the first time, it should be the best surgery she should get. Many times you have these women coming in, they've moved from one hospital to another, and they've had incomplete surgeries. So if we can be able to grow together, get better, and do the right thing, we'll be able to help these women very, very much. Yes, so with those few words, as you can see, there is a lot for us to pick through this. I'll invite Dr. Spire Kiggundu to take us through the next, to give us the presentation on transvaginal evaluation of endometriosis. Thank you. Dr. Spire, you're welcome.
Thank you very much, Dr. Gideon, for the humble introduction. I don't know if I'm audible enough.
Yes, you are.
Audible enough?
Yes, you are.
And can you see my slides?
Yes, we can.
Yes, we can see the slides.
I welcome everyone to this discussion. I cannot overemphasize what Dr. Gideon has said. We are all stakeholders in this. Endometriosis burden is real, not just in Uganda, but in the whole of Africa. The reason we are doing this is to make sure that we bring everyone on board, at least with some information of endometriosis. Who knows? Everyone has a contribution. Some people are here as clinicians, specialists, surgeons, urologists, but we also have patients on this platform. So we shall start with our discussion tonight. We are going to look at the transvaginal evaluation of endometriosis and how we use the ultrasound to guide diagnosis, staging, and treatment. Period pain is not normal, and we cannot just live with it. I think this is a strong statement. I should just say that it is not right for any woman to live with period pain. And we should all demystify this and make sure that period pain is taken seriously right from menarche, because in my experience, I've seen a lot of adolescent young girls who are battling with endometriosis. So one of the gist of the discussion today is to make sure we give as much information so that everyone can be able to catch endo at the early stages. I have no disclosures for this presentation. It is purely academic. I borrowed this slide from Professor El Minawi, who came up with these statistics. He looked at the factors contributing to inadequate reporting of endometriosis among African indigenous women. And one of the things that strongly came up was the lack of awareness of endometriosis and the poor access to diagnostic and therapeutic facilities. They also noted that the primary reason was culture. The misguided notion that a woman should only endure the pain that comes from menstrual cycles, but also not talk about it, leads to misdiagnosis, improper treatment, and even more complications. And as Dr. Gideon noted, there is a higher prevalence of endometriosis, which was reported even in affluent African women. This is a brief background. We know that about 40% of women of reproductive age have endometriosis, and 37 of them have deep infiltrating disease. 90% of these, the disease is located in the posterior compartment, and 66%, which is a big statistic, is on the bowel. The symptoms are mainly chronic pelvic pain. Dysmenorrhea means pain on menstruation. Dyspareunia means pain on deep coital intercourse. And dyschezia, pain on defecation. So we should not omit those symptoms. Sometimes we call them the 4Ds. So when someone presents with the 4Ds, you usually want to think about endometriosis. And when the condition becomes long-standing, then problems often become constant. Some women will come to you with pain while urinating. Others will come to you with deep-seated symptoms in the nerves, and they often complain of pain while exercising. Then you have a variety of women who present with bloating, nausea, and vomiting as bowel symptoms. Of course, depending on the stage of endometriosis, we also have seen women presenting with heavy and irregular bleeding. This diagram shows us a variety of locations of the disease. This is the anatomical presentation of the pelvis. And here we see that the pelvis is divided into compartments. In the anterior compartment, we have the urinary bladder and the urethra. You have the uterus in the middle, and then the bowel, the lower part of the bowel, that is the rectum and rectosigmoid posterior. So endometriosis is usually common in the bladder uterine recess, posterior to the uterus, sometimes adenomyosis, if it goes to the uterus, in the recess behind the uterus or between the uterus and the rectum, what we call the rectal vaginal space, and often you can find it in the vagina. These are the different shades you come across on laparoscopy. Some women will present with shades of peritoneal disease and blood in the peritoneal cavity. And this emphasizes the theory that most of the women who have endometriosis have retrograde menstruation. In my practice, I found a lot of women with blood in the pelvic cavity. And these are women who often will tell you that they have menstrual cramps. So the theory of retrograde menstruation is strong. And we believe that young adolescents who often complain of cramping from menarche at a high risk of endometriosis because of this backflow. Then here you can see more fibrosis and scarring behind the uterus in the posterior compartment. And then you also find ovarian involvement with endometriomas. Endometriomas basically means a collection of blood within the ovaries. It is very important that these women are examined carefully. I always emphasize that you put a spatula and look in the posterior vagina and behind the cervix. Often you might catch a lesion in the posterior fornix, and this is a telltale sign that the disease has gone into the rectovaginal space. And then it is mandatory that every man should have a bimanual exam where a gynecologist or any examiner puts a finger in the vagina and one finger in the rectum. This will help you to look at the location of the uterus, but also appreciate the adnexia, the parametrium, and any lesions in the bowel. Do not miss doing a vaginal exam, because before you put in your TVS probe, you should have a clue on the kind of lesions you would expect to find. Of course, the surgeon needs to be familiar with imaging, and the extent and localization of the tumor must be familiar to the surgeon before any attempt to treatment. Ideally, palpation, ultrasound, and surgery should be in one hand. And this emphasizes the reason why gynecologists should really know how to perform an endovaginal scan. I also want to emphasize that previously, laparoscopy was the gold standard in the diagnosis of endometriosis. But with changing trends of modern ultrasound, better scale scans with better resolutions, we can now pick out endometriosis lesions with ultrasound before we put a scope. So we demystify the thinking that laparoscopy is the gold standard for the diagnosis of endometriosis. It is not true. For example, if you look at this lesion on laparoscopy, you realize that there is a lesion in this area of bowel, but you'll never know how deep the lesion is. When you look at the ultrasound image here, you realize that there is a nodule in the anterior wall of the bowel. There is no way you are going to see this nodule if you put in a scope at laparoscopy. You have to be able to pick up these lesions so that you plan carefully. So that is one of the things we want to emphasize in this presentation. Why ultrasound or TVS? Because it is a tool and a very good tool in the hands of a gynecologist, because the gynecologist understands the disease better, and we emphasize that a gynecologist would be in a better position to scope or scan the patient. It is faster, it is cheaper, it has less contraindication compared to other modalities like MRI or laparoscopy where you need anesthesia, and it is a dynamic examination. You can always record in real time. When you look at this image, you realize that most times when you put in a scope at laparoscopy, what you're going to see is the tip of the iceberg, a small part of the lesion. The truth is most of the disease is below. So the lesions we often see at laparoscopy are considered superficial lesions, but we have too much of the disease in depth. So that's why TVS would come along as a very strong modality in helping to pick up deep lesions in the pelvis. Preoperative ultrasound mapping of all endometriotic lesions is therefore necessary before surgery. There are many reasons why we need to do pre-op evaluation, because we have different levels of practice. If you are a generalist, you can easily plan and refer the patient appropriately, but sometimes you realize that you might need, for example, a bowel surgeon, a colorectal, or a urologist to join your team. So you need to plan adequately. What is the problem therefore? The problem is there is lack of standardized definition in the ultrasonographic classification of DIE, and this is a general concern. This lack of uniformity when classifying anatomical locations and the extent of the disease contributes to the considerable variation in the reports that we get from different centers. So today we want to have a uniform way of reporting endometriosis. Does language matter? Obviously, the ideal terminology, the International Deep Endometriosis Analysis came up with terminology that we should use when we are looking at lesion of endometriosis. And they compartmentalized the pelvis. First of all, you look at the bladder anteriorly with the urethra. You look at the posterior vagina. You assess the uterus independently, and you assess the bowel posteriorly. The reference point is usually the internal os, and at the internal os, that is where we expect to see the torus. And sonographically, this is major what we consider our reference point. Every time you're lost with a probe, look for the cervix, orient, look for the internal os. You'll be at the region of the torus. The uterus acros will be either side, and you'll be able to pick out lesions posteriorly. Even when we are measuring bowel lesions, we usually measure bowel lesions from the point of the internal os. The anal vag is usually about 8 centimeters from the internal os. So any lesion below the internal os is considered a lower rectal lesion, and any lesions above the internal os is considered an upper rectal lesion. So you need to understand the anatomy very well before you scan. Some patients will come to you with a frozen pelvis like this, and a frozen pelvis basically means that all the structures posteriorly are matted together. Several papers have looked at ultrasound in a systematic way of describing endometriosis. And this is where the idea criteria came from after consensus from different groups. And several meta-analyses talk about the systematic evaluation of women with suspected endometriosis. And the one we use is the 5-domain sonographic-based approach. This is what we are going to describe today. How do we do this? Using the ID criteria, we compartmentalize the pelvis. We look at the pelvis into compartments, the anterior compartment and the posterior compartment. In the anterior compartment, we have the urinary bladder, we have the ureters, and of course, we assess the kidneys for ural obstruction. And then in the posterior compartment, we look at the vagina, we look at the uterosacral and cardinal ligaments, and we look at any lesions in the bowel. And when you've done this, we consider that you've looked in all the possible areas where endometriosis will commonly go. So this is the systematic evaluation according to the IDEA criteria. First of all, we look at the routine evaluation of the uterus and the adnexia. And here we look for signs of adenomyosis and the presence or absence of endometriomas in the ovaries. That is considered the first step. In the second step, we look at the transvaginal sonographic soft markers. And here we look for site-specific tenderness. When you put a probe and you ask your patient if they feel pain, it is common that in those areas where they feel pain are areas of disease infiltration. So you should focus more in those areas. So site-specific tenderness is very important on a transvaginal ultrasound scan. Of course, you don't want to hurt your patient. Tell them that they should let you know and you stop when you are causing a lot of distress. Again, in the second step, we look at ovarian mobility. It is very important to look at the mobility of the adnexal structures. The ovary should be seen moving along the pelvic side wall and over the uterus. And if the ovary has any adhesion, or rather adhesions, you should be able to see them. In the third step, we look at the status of the pouch of Douglas, that is the posterior aspect of the uterus in real time. And this is where you look for the sliding sign. Make sure you do a sliding sign maneuver in all your patients because it helps to show you whether the uterus, which is a mobile organ, slides nicely over the peritoneum, anteriorly over the bladder, and posteriorly over the rectum. If you do not have a sliding sign, it is evidence that you might have a frozen pelvis or adhesions. Then lastly, we look for nodules of DI, what we call DI, deep penetrating endometriosis, nodules, and both in the anterior and the posterior compartment. So that's what we consider a full IDEA evaluation. At laparoscopy, this is what you would consider a normal pelvis. The patient is in that position. And when you put in a scope, briefly, this is what you should see. You should see a nice and clean pelvis. The adnexia is free, the tubes are free. You have the bowel posteriorly, you have the uterus. This is what you call the pouch of Douglas. This is the thorax. That is the thorax, commonly the first area where endometriosis will go. Then you have the uterosacral laterally and the rectum posteriorly. In our nomenclature, we shall call this compartment A, then compartment B is the lateral pelvic wall, and compartment C is the rectum. So in the description of these lesions posteriorly, that is what we usually do. An image like this at laparoscopy would be very confusing because you can hardly make up anything. The ovaries are stuck onto the uterus with adhesions. You have the tube with hydrosalpinx also stuck on the uterus. You cannot see the bowel. It is difficult to really make up for anything in this pelvis. You do not want to get in this pelvis without doing a proper vaginal scan. That is what we call a frozen pelvis. I want you to compare the two. And I want to emphasize that ultrasound scan can see much more than laparoscopy. At laparoscopy, this is the kind of image you get. As we said, you cannot make up anything. You will not know whether you have lesions in the bowel. You will not be able to tell whether you have endometriomas because the ovary is hidden. But down here, when you look at the when you look at the ultrasound, you realize that in real time, we can try to compare the two images. At ultrasound, you should be able to see the uterus, the ovary. You can see that the ovary is stuck onto the uterus with an endometrioma. You can as well pick up the bowel lesion in the anterior wall of the rectum. You will not be able to see this otherwise at laparoscopy. That is why we emphasize that ultrasound is able to pick up all the lesions that you would need compared to laparoscopy, and therefore it should be mandatory before any intervention. The Porch of Douglas sliding sign evaluation is important. As we said, you always have to look at the position of the uterus. This uterus is anteverted, and this is a common thing you see in young women. And at ultrasound, you see something like that. And then when you have disease in the Porch of Douglas, most often you're going to find a uterus that is retroverted, retrofixed, because the adhesion in the posterior Porch of Douglas are going to pull the uterus back. And this is a deformity that we often want to correct at surgery. And here you can see the uterus is stuck at the bowel. It is stuck around the areas of uterosacral, and most likely this will be a frozen pelvis. So you can pick out this when you do a very good bimanual examination. A normal sliding sign should look like that. At ultrasound, the uterus moves that way and the bowel moves that way in opposite direction, and you can see the uterus sliding nicely over the peritoneum. If you have a little fluid in the Porch of Douglas, it is even better. You have the probe here, you have the sub-vagina around there, you have the cervix around there. This is an abnormal sliding sign. Look at this. The uterus moves together. Of course, this is the normal one. Again, you have the uterosacros there, you have the probe. And if you compare the two images, you'll notice here it moves nicely, and here you have absence of the sliding sign, because the uterus and the vaginal wall and the bowel move together. So this is a sign of a frozen pelvis or adhesions compared to that. So the sliding sign should be added to every routine pelvic ultrasound. In the anterior compartment, we usually divide the bladder into 4 zones, where we look at the trigon, the base, the dome, and then the extra-abdominal. So the first thing we usually do is look out for the urethra. When you look for when you find the urethra on a half-full bladder, you'll be able to see the ureters on either side, and you can be able to trace all the ureters to the point of where the uterine artery crosses. And I want to tell you that at laparoscopy, if you met a lesion like this, it will be very confusing, because you can see an area of fibrosis. This is the obliterated umbilical artery. There is a deep lesion of endometriosis here. And when you open the lesion, you notice that it is a full thickness lesion going all the way to the bladder. If you did not do a correct TVS before surgery, you're more likely to miss this kind of lesion. So that is why when you do a good TVS, you should be able to see such a lesion in the bladder anteriorly. You should be able to see that the bladder does not slide nicely with the uterus. And you can also see the ureter running behind the ovary, and see an area of hydronephrosis. So in this kind of patient, you'll be able to tell that there is ureter obstruction because of the lesions in the ureteric area. And here, every time you see a dilated ureter, you have to look at the kidneys for signs of hydronephrosis. And when you find hydronephrosis, then it obviously means that the patient has ureter obstruction. Then we assess systematically, we go to the uterus. The uterus is usually assessed individually for adenomyosis, and you will see a bulky globular uterus with small myometriosis. Sometimes you see shadowing. Again, in the transverse view, you are able to see the endometrium, which should be well measured. You see the uterus is kind of globular. Try as much as possible to measure both walls of the uterus. You should be able to measure the anterior wall and the posterior wall and look for discrepancy. In adenomyosis, sometimes you see this obvious discrepancy, giving you what we call a question mark sign. And then you take your time to look at the endometrial junction, because sometimes you see those little islands between the endometrium and myometrium, which sometimes are much better elucidated out of MRI. So don't miss adenomyosis at ultrasound. Of course, when you see adenomyosis, then you have to use the Musa's criteria to try and classify the adenomyosis. Is it globular? If adenomyosis involves the entire uterus, then it is a globular type. If try to measure the distance between the endometrium on either side and see if there is any discrepancy. Look out for cysts. Sometimes you have cystic adenomyosis with leakage into the endometrium. You can have hyperechoic little islands. Do not ignore those for infarcts. And fan-shaped shadowing shows that the uterus is infiltrated. Then you can also look at some endometrial lines and hypervasculature. This is Doppler. When you see lesions of adenomyosis on Doppler, they will give you what we call a translesional vascularity. Unlike myomas, which give you a peripheral outline, adenomyosis will give you translesional vascularity. So try to look out for all those lesions, look at the Musa's criteria and understand it. Next, we look at ovarian endometriomas, and endometriomas will typically give you what you call a ground glass appearance, something like that. And when you see an endometrioma, the next thing you want to know is the ovary stuck on the uterus side, or is it stuck on the pelvic side wall? You have to measure the ovary and take proper dimensions, because endometriomas really generally have an effect on fertility. So here we see a nice uterus, and behind it you see an endometrioma with the ovary stuck onto the posterior uterus. And then in the second video, you can clearly see that the ovary does not move on the side of the uterus, and it is also fixed on the pelvic side wall. So this is a sign of adhesions, a non-moving, and in this image you see kissing ovaries. You have the left ovary here, the right ovary here. They're not moving on the side of the uterus. They're not moving on the side of the pelvic wall, and this is not a very good sign where the ovaries are stuck in the pouch of Douglas. So you should be going for your surgery knowing the complexity of the adnexal lesions. It is not uncommon that sometimes your patients will have a hydrosalpinx, which is really more of a hemosalpinx with blood collection within the tubes. And in an image like this, you are able to pick up the tubular structure of, you have a nice ovary there with the tubular structure coming up of a hydrosalpinx. So you can easily pick up hydrosalpinx as well using a TVS. So we shouldn't miss these clear lesions because they're quite typical. You can clearly distinguish between the ground glass appearance of an endometrioma from any other cysts, complicated cysts in the ovary. What about the posterior compartment? Evaluation of the posterior compartment is a little bit more complex, but with practice, you can pick the skill of looking at the lesions in the rectovaginal septum. Clear rectovaginal septal lesions are very rare in endometriosis, but when they exist, you can see them running down all the way to the anal vag, and these are lesions sometimes you would see on a speculum in the posterior fornix. So do not miss those lesions in the posterior compartment. We are going to look at what a normal posterior vaginal fornix looks like. In this image, we can see you have a probe there with a little bit of gel. It helps you to delineate the vaginal wall. You have the cervix. Remember, we said the cervix is our point of reference. Just make sure you pick out the area of the internal os in that area, and it's going to be our reference because below the internal os is what you call the torus. And the torus is an area where endometriosis is very common. Then here you see the uterus sacral on one side. That is the torus. Always when you put a probe in anterior fornix, try and pick out the internal os. Then try to slide down with a probe with a gentle push. You should be able to see the uterus nicely sliding over the vagina. And here you can see the probe gently going down posteriorly with a little bit of fluid in the POD. You should be able to pick up the lesions in the area of the torus. Here you can see at laparoscopy, you have a lesion in the area of the torus, which is easily picked up at ultrasound. And these lesions are sometimes very typical. Do not confuse them for bowel lesions. Again, in the area of the torus, we should be able to pick up, this is the torus, we should be able to pick up the uterus sacros. This is the cul-de-sac or the POD, and any lesions in this area should be well seen. This is the normal torus, as you see, and here we have a nodule, which is a dark area which is quite thickened. Again, here you see the normal uterus sacros, and when the uterus sacros are thickened, you should be able to pick them up, because remember the uterus sacros are just thickening of peritoneum. So do not miss these lesions of thickened uterus sacros on a TVS. In this video, we can see the probe, it's the area of the vagina, and you can easily pick out the lesions. The vaginal posterior fornix, the peritoneum, and the uterus sacros will stand out for you. And this is what a normal uterus sacral looks like. When you compare it with this image, you can see the vagina is thickened, and you have a big lesion here in the area of the torus, which is a bit hypoechoic. The last thing you want to look at is the bowel, and bowel lesions usually change the game of endometriosis, because what you don't want to miss is the bowel lesion and then you find it at laparoscopy or surgery. because then you have not prepared the patient, you have not done proper bowel care. A good view of bowel should look like this. This is the entire area of bowel. You have the serosa, you have the muscularis layer here, and this muscularis layer is divided into two, the outer longitudinal and the inner sacral layer. This is the bowel lumen without content, or the submucosal layer, and this is the posterior muscularis mucosae. So these layers tend to stand out at TVS, and what we usually do is we follow the anterior rectal wall, the area of muscularis mucosae, and we should be able to see any endometriosis lesions in the anterior bowel. It is difficult to find endometriosis in the posterior bowel because of the mesorectum. Again, here you have the cervix, you have the serosa. The next layer is the muscularis, divided into two by a thin hyperechogenic rim, dividing the sacral and longitudinal layers. That's the lumen. And if you're careful, you can find a lesion like this, which is typical hypoechoic lesion of endometriosis. Try to measure your lesion. This is quite a large lesion of endometriosis in the bowel. You should be able to measure it, measure the depth of infiltration into the muscularis layer, and this is going to have to help you to plan your surgery, because some patients will need a segmental resection, others will need shaving of the lesion. You do not want to miss these rectal lesions because of recurrence. It is also wise to be able to tell the distance of your lesion from the anal vag. So if you pick out a lesion like that, you should be able to measure the lesion from the anal vag. How do you do that? It is simple. You look for the internal os as our point of reference. We said the internal os is about 8 centimeters from the anal vag. So when you see any lesion around the area of the internal os, you are within 8 centimeters of the anal vag. And any lesion that is close to the fundus of the uterus is in the upper rectal sigmoid. So these lesions should be marked up, and the sonographer should be able to tell you the location of the lesion, the size of the lesion, the depth of infiltration of the lesion, because it's going to guide you in the subsequent management. With that, I have to say that the first surgery should be the last surgery, because now that you've planned, you know the type of lesions you have. You should never get into the patient before doing ultrasound. Ultrasound is mandatory before surgery, and it should be planned. Good ultrasound allows for exact counseling of patients. Possible complications can be calculated and discussed. And of course, YTVS, obviously, we know that compared to MRI, TVS is cheap. It is repeatable. It is a dynamic examination. It is very safe in the hands of a gynecologist. You do not need too much preparations, unlike MRI. And it helps you to pick up the lesions and even the symptoms as you examine in real time. These are some of the templates that you will need in your scan room to try and do a systematic evaluation of an endometriosis patient, because these templates kind of pick out all the lesions in several compartments following the ideal criteria. First of all, you look at the bladder here, and then you should be able to tell all the lesions in the layers of the bladder. You look at the vesico-uterine space, and when you look closely, you realize that we have check boxes. Every lesion you see, there is a plus or a minus. If you see any lesion, for example, in the base of the bladder, you should tick. You do not see any cross. So it makes it easier to evaluate, because if you have two people doing this ultrasound, one is doing the checklist, the other is scanning, and as you run together over time, you get a proper understanding, and it should not take more than 15 minutes to do this assessment on a patient. Lesions in the rectovaginal space, either plus or minus, lesions in the ureter, is it the right or the left ureter? You have to mark them out. The lesions of the uterus, that is adenomyosis, the endometrial cavity, what is the size, the type of adenomyosis, is it cystic, is it diffuse, is it subendometrial? You have to be able to map up all those things on your checklist. Then you look at is the pouch of Douglas obliterated or free? If it's obliterated, you note. If it is free, you mark with an X. Then you look at the adnexia, the right and left, because adnexia is a paired structure. And you should be able to tell whether the ovaries are free. Do they have endometriomas? What are the size of endometriomas? Where is the ovary stuck? Is that stuck on the lateral pelvic wall? Is it stuck on the uterus? All this has a bearing on the management. Then we look at DIE lesions in the posterior compartment, the rectovaginal space, the vagina, posterior vagina, the uterosacros, left and right, the thorax, lesion in the thorax, and their size, the right parametrium, the left parametrium, and lastly, you look at the bowel. Are there any lesion in the bowel, and what is the location? Is it in the cranial aspect? Is it in the wall? How deep is the area of infiltration? And then you should be able to measure the distance from the anal vag, because that has a bearing on the planning of your surgery. If a patient has a lesion in the lower part of the rectum, most likely they are going to have a difficult resection anastomosis with maybe an ileostomy or plus or minus a colostomy. The patient has a lesion anywhere above 6 centimeters, it's going to be much more easier to do resection anastomosis. So this information is needed by the surgeon for planning, and obviously then you look elsewhere. Extrapelvic endometriosis. Is there endometriosis in other areas beyond the pelvis? For example, hydronephrosis, the diaphragm, and all those areas. Maybe those sometimes are better elucidated by MRI. So you can see that if you have this kind of checklist, then it is a comprehensive assessment of your patient. You should never miss any of the lesions, and this checklist will automatically help us to stage your patient and plan management. Every endometriosis sonography room should have a template like this, which follows the ideal criteria in order to get a report. Lastly, when you've picked up all your lesions, you have them on your checklist, then we use what you call hashtag Enzian classification. Hashtag Enzian classification is a consensus that was drafted by a group of endo societies. And you remember previously we used to have many different stages of classification, which were a bit confusing, but hashtag is a descriptive classification which shows you all the lesions of endometriosis. It tells you about the superficial involvement of the disease and then the deep involvement of the disease. So in a hashtag Enzian classification, we look at the peritoneum and you try to map up the lesion of the peritoneum. If the lesion is less than 3 centimeters, then we score it a P1. Any lesion between 3 and 7 is a P2, and any lesion more than 7 centimeters is classified as a P3. Remember, peritoneal lesions sometimes are quite difficult to see on ultrasound, though we can, with a good endo eye, they are better seen on laparoscopy. So hashtag can either be via laparoscopy, ultrasound, or a combination of the two. But ideally, at the end of ultrasound, you should be able to see all the lesions in the ovary, in the tube, in compartment A, compartment B, compartment C, and distance spread. I'll just quickly go through this, and I must say that every patient who has endometriosis should have a hashtag classification. because this is a universal, dynamic, and widely accepted method of staging. And if a patient doesn't have a hashtag staging, then their disease is not properly understood. So in a hashtag, we look at the ovaries. Remember, the ovary is a paired structure, and we usually start with the left. That's why we say over on the left, over on the right. All paired structures have a slash. For example, the ovary, the tube, and compartment B, which is the parametrium. Single structures like peritoneum, compartment A, which is the area of the torus, and the rectum, considered separately. So with the ovary, we look out for the lesions in the left ovary and the right ovaries. And if you have an endometrioma in particular, less than 3 centimeters, we score you 1. If you have an endometrioma between 3 and 7, we score you 2. And anything more than 7 is scored 3. So if you have an endometrioma on the left side, for example, between 3 and 7, we say O2. If you have none on the right side, we say O0. The same with the tube. We have to look at the adhesions. If the tube is stuck on the pelvic side wall and on the uterus, we give you a T1. If it is stuck on both sides of the ovary and the pelvic side wall, you have a T2. If it is literally stuck everywhere on all sides of the uterus and the pelvic side wall, you take a T3. And you can also look at patency, plus or minus. Compartment A usually is the posterior vagina, the torus, and the rectovaginal space. And lesions there are seen properly on ultrasound, as we saw earlier. You measure the lesions. Anything less than 1 is scored as a 1. Anything between 1 and 3 is a A2. Anything more than 3 is A3. So these lesions can be seen and measured. Compartment B is usually a paired structure, and that is the parametrium. Here we look at the uterosacrals and the cardinal ligaments. And again, we measure the same way. Compartment C is the rectum. We look at the anterior wall of the rectum, and we should be able to measure those lesions accordingly. Then F stands for distance spread. For example, if you have adenomyosis, we say you have FA. F adenomyosis. If you have disease in the bladder, we say FB. If you have disease in anywhere of the small bowel, for example, appendix, which is a common culprit, or any bowel lesion, we say FI. Any lesion on the ureter will give you an FU, and distance spread to the diaphragm, lung, nerve is measured accordingly. So that is the hashtag Enzian staging. So at our center, at every ultrasound, we usually stage our patients. Every patient has a hashtag classification, and this will guide the management. It will decide whether you need a colorectal team. It will decide whether you need a urologist. It will decide on your fertility desires, on what you should do about your eggs. We might need to pick your eggs, freeze them, and then advise you about surgery. So I cannot emphasize the advantage of doing a hashtag classification. These are peritoneal lesions as seen on the scan, and you see there's a small lesion 1, we score a P1. Here you see lesions which are more than 7 centimeters, scored P3. Again, this is to show you at laparoscopy. You can also see lesions at the uterosacral. The left is free, scored a B0, and the right has a lesion which is about actually more than 3 centimeters, and that is B3. So the score will be B0 over B3. Quite simple. It's not difficult. In conclusion, I would say that we have achieved a consensus in relation to approaching and reporting of endometriosis ultrasound. And this will result in consistent use of nomenclature when classifying TVS findings and surgical diagnosis of endometriosis lesions. And I have to say that this nomenclature should be uniform. If a patient moves from center A to center B, they should have the same nomenclature, a properly filled hashtag, NZN classification, which basically talks about the patient staging and in a language that every endometriosis doctor should know. And consistent use of definition to classify the disease location will in turn, of course, optimize the objective interpretation of research, allow reproducible assessment of the pelvis, and potentially lead to improved clinical care of women who need DIE interventions. So what next? What next? It all depends on you. If you are not yet familiar with endometriosis ultrasound, you can easily get there. You just have to start training. Every time you get your patient, go through the drills. It doesn't matter whether they have endometriosis or not. You can scan around them, get used to doing the sliding sign, get used to seeing the bladder, get used to seeing bowel, all the layers. When it becomes routine, then you can never miss these lesions of endometriosis. And of course, your surgery will improve simultaneously. I want to thank you very much for listening. We shall entertain questions. I don't know if you have any questions in the chat box or any questions from the audience. Thank you very much for listening.
Okay. Thank you very much, Dr. Spire, for that very detailed presentation. I'm sure we've been able to pick one or two things in the presentation. I know it's a lot. There is a lot of information that has come through and a lot for us to think about. There are a few comments in the chat box, but before we get there, I will invite some of the people on the panelists, Dr. Stephen Bawakanya, for any comments or any addition, very briefly, and then Pius and then Mr. Sally Jerome after, and then I'll get to the comments in the chat box. Dr. Stephen Umayana is a senior consultant with Impara Regional Referral Hospital. Please.
Thank you very much, Dr. Spire, for the presentation. You have really emphasized the importance of ultrasound as regards to endometriosis diagnosis. Of course, why should we do ultrasound? It has been talked about, but of course, we need to know the etiology of those symptoms, because many of our patients present with pain, and seeing a woman with pain, a doctor starts shaking, because a woman will come with so many medical forms and she has taken many medications. And of course, this lady has lost trust because everything has been given to this lady. Am I audible?
Yes, you are, Doctor.
Hello?
Yes, you are.
Yes.
Audible.
Yeah, ultrasound is really very important because it will help us evaluate the etiology of symptoms and also map disease location and also ascertain the extent of the disease. And of course, as a surgeon, many times we have encountered frozen pelvis and we end up doing subtotal hysterectomy. I've seen so many surgeons gynecologists ending up doing a subtotal hysterectomy. That is because they don't know whether it was endometriosis or something related to, maybe leading to that. So we need to properly evaluate these patients, and ultrasound comes into play. And as a gynecologist, you should be knowing how to use a vaginal probe. So in case you are trying to buy an ultrasound machine, make sure that that machine has a provision for a vaginal probe. And in our community, endometriosis is, people perceive endometriosis as a rare condition. And because it is perceived as a rare condition, there will be a delay in diagnosis. And what does that one translate into? that many of these women will present to us when the condition has spread very wide and the women have lost trust and they have got a lot of medications. And of course, some of these medications have not worked to some of these women. So we need to create awareness as far as this condition is concerned, because these young girls, when they start menstruating, they feel some pain, and this one is perceived to be very, very natural. I mean, as a natural phenomenon, which is okay. But if this pain is unbearable, there is a need to reevaluate this pain. What is causing this unbearable pain? And of course, as these younger women try to achieve higher academic goals, and of course, they will delay childbearing, endometriosis will come in because these women have been exposed to so many menstrual cycles. And of course, when they start, maybe when they want to bear children, they can't achieve any pregnancy. So as gynecologists, we should try to find out why isn't she able to achieve any pregnancy? So one of the causes might be endometriosis. So we need to pay attention to endometriosis. And of course, pain, pelvic pain. What is causing this pelvic pain? Don't forget that endometriosis might be in the background. Don't just give medications. So creation of awareness about endometriosis, about this condition, should be emphasized. And this one should start right away in the school so that there's no delay in the diagnosis. And of course, we need to bring on board other members. Sonographers, they are very important. So instead of doing only a transabdominal scan, one should go ahead and do a transvaginal scan, such that there's a proper evaluation of of these women who present most especially with infertility issues, with pain, pelvic pain, and other issues and other problems related to their failure to conceive. So that's what I have to say. Thank you very much.
Yes,
hello?
Thank you very much, Dr. Stephen. And thank you for those comments. Indeed, we need to be encouraged to take that first step of doing the transvaginal scan. It's we are all on this journey of learning at different stages, but with time we shall get there. I think it's important that all of us start this journey one step at a time, and we will get there. Yes, any comments from Mr. Pius Kajumba? I don't know whether you are around, Pius. Okay. Mr. Sally Jerome?
Yes. Are you hearing me?
Yes, that's Mr. Jerome.
Mr. Jerome?
Yes, Jerome. Jerome is a medical imaging technologist. Yes, please go ahead and give a comment briefly. You're very welcome, Mr. Jerome. Please go ahead.
So, thank you very much. First of all, I want to thank Dr. Kiggundu for the comprehensive presentation he has given. The remarks I was here as medical technologist, I saw a question in the chat when someone was asking about MRI.
Mr. Jerome. Yes, we're not getting you very well. I don't know that you could try and be clear. We're not hearing you very well.
Are you hearing me now?
That's better.
I think he's very far from his device. He's a bit far from his device. Can you get closer to your device?
Please get closer to the phone or to the device. Yes.
Are you getting me now?
Yes, now we are better.
That's better.
Okay. So I would like to thank Dr. Kiggundu for the comprehensive presentation he has given. On my side, as medical imaging technologist, I had the comment in the chat. Someone was asking MRI and transvaginal scan, which one will delineate the lesions better. So now, every part of the modality has an advantage over the other. But ultrasound, for the best advantages it has, it is cheap, it is accessible, and it is actually, by study, it gives 97% of the lesions will be shown by ultrasound. So it is only if you've missed an ultrasound when you go to, you will have to go to MRI for lesions like distant lesions, like the pleura in the lungs. You can go ahead and do an MRI, but the first line modality should be ultrasound. Then another thing I would like to talk about, endometriosis. Usually on scan, there are many things that will trigger you a sign that will help you find other lesions. The first one, as Dr. Kiggundu said, the fibrosis, endometriosis, where the tissues will trigger an inflammation that causes healing by adhesion. So when you put your probe in the fornix and try to apply a little pressure, the uterus has to slide over the rectum smoothly, as we demonstrated. But if we have endometriosis, you will see the two moving as a batch. When you push the uterus gently, it will move along with the rectum. And that will be one of the triggering signs. Then number two, when you find one lesion, please don't be excited. Because sometimes when you find a lion in a jungle, so don't kill one and you think you have killed all. So you might scan and find an endometrioma. When you find an endometrioma, then all a low-lying ovary. Because when you have a low-lying ovary, try to do sliding sign out to push to apply a gentle pressure to see it if it is freely mobile, and it is not, meaning the adhesion holding it either to the side wall or to the uterus. So that is a sign that will trigger that there might be other reasons. I request colleagues that you should follow the protocol of transvaginal ultrasound in endometriosis and look at all the anterior. You find one lesion, you might miss another, and then you misguide the person who is going to work on the patient. I think with that, maybe if there are any other questions, but what I encourage is that we practice more and more. Practice makes perfect. When you practice more, the more lesions you see, the easier it's going to become for you to master the protocol and find lesions. Thank you very much, unless if there's a question.
Okay, thank you so much for that in-depth addition or supplement. Indeed, like you've ably said, many times when a scan report comes in and it says there's an endometrioma, you can be very assured that there is deep infiltrating endometriosis. which they will not have reported, but is actually there. So you might go in to just maybe drain this endometrioma or do something about, do a cystectomy, yet there is actually deep infiltrating endometriosis, which you haven't prepared for. So we need to, like you verbally said, that we need to get into the habit of perfecting or routinely going through a very systematic approach of doing these scans, and that will be our foundation for ably planning surgery and being able to help these women going forward. Thank you.
Dr. Mugisa, I have a simple
yes,
addition
yes,
question.
Yes, Dr. Sematimba.
I want maybe Dr. Spire to clarify, or Jerome, when you're doing a sliding sign, where exactly is the probe? Is it anterior fornix or posterior fornix? It's very important. Then to stress the significance of the junctional zone in the diagnosis of focal and global adenomyosis. Thank you.
Okay, thank you for that question. Do you want us to take the questions first and then answer at the end?
I think we can take the questions right now.
I would suggest we take the questions and then we'll answer them at the end. Okay. If that's okay with us. Yes. Before we take the questions, I'll ask Dr. Ezekiel Macha from the University of Nairobi, who is an endometriosis researcher and scientist. He will come in and share one or two things with us. Dr. Ezekiel Macha, you're very welcome. Please.
Thank you very much.
Yes.
I hope I'm clear, Dr. Mugisa.
Yes,
Am I
you
clear?
are. Yes,
Okay,
you are,
thank you
Dr.
very
Ezekiel.
much. Yeah, thank you very much, Dr. Mugisa, and also the Association of Laparoscopic Surgeons of Uganda, together with Dr. Spire, for inviting me to attend this webinar. First of all, what I can say is that endometriosis is a very, they call it a silent monster, and it's making our putative ladies to suffer in silence. And we need to come up with one voice, and that one voice is to talk about it, the disease, to remove the associated stigma, and at the same time being in the front line in the management of the condition. Also, what I need to say is that endometriosis management requires a multidisciplinary approach, and I'm very, very happy with what you are doing here right now, because I can see we have doctors in the room, we have patients. I think I've seen a comment from a patient. We have endo warriors in the room, and that's the best approach we can do as far as endometriosis management is concerned. So as Dr. Mugisa, you have said, I'm an endometriosis researcher, and I've been in the field of endometriosis for the last 15 years, basically trying to find early diagnostic markers for this condition. Apart from that, apart from science, myself and also a number of colleagues from Kenya, including also Dr. Spire, we have been in the front line championing about endometriosis awareness in the region and also in the continent. And I think Dr. Spire might talk about the process we are doing right now. We are in the process of forming Pan-African Society of Endometriosis, which is going to be launched in Cairo in September. I think maybe Dr. Spire will talk about that. So what I can say is that as members in this field of endometriosis, we need to talk with one voice. We need to look for ways in which we can work together for better management of endometriosis in the continent and also in our region. And I'm very, very happy about the topic which has been discussed today by Dr. Spire. That's the use of ultrasound. As you know, Africa or the developing countries, we are resource constrained. And initially, laparoscopy has been the main standard for diagnosis of endometriosis, which is very, very expensive, as my colleague said. I think Dr. Stephen talked about that. So when we have alternatives, alternative method, which is a bit cheaper and which is a bit non-invasive, then that will be the best way to go forward. I'm very sure still laparoscopy is the gold standard, but if we need to embrace other methods for diagnosis of endometriosis, and I'm happy that Dr. Spire and also the other laparoscopic surgeons from Uganda, you are embracing ultrasound, and I'm very sure when we have a number of diagnostic tools or diagnostic techniques, that's the best way to go forward. Last but not least, maybe I'd like to invite you to the 3rd East African Endometriosis Congress, which will take place in July, and I've shared a form online. And also, I've also shared the previous events which took place, and I'm happy that Dr. Spire attended. Then also we had two doctors from Uganda. So we had the 1st East African Endometriosis Conference. I've shared a link. Then we had the 2nd East African Endometriosis Conference, which took place last year. And we were very, very happy to host Dr. Spire in Nairobi. Then this year, in fact, the webinar which we had today, we are going to have some trainings on the same, and also some surgical operations on ultrasound. So we have experts from Kenya, we have experts from Uganda, then we'll have experts from Europe. So they are going to take part, they are going to share experiences in ultrasound and also how it can be used as a diagnostic marker for endometriosis. So once more, I wish to thank the Laparoscopic Association of Uganda, Dr. Mugisa, Dr. Spire, and also all my colleagues for organizing this webinar. We must be in the front line of creating endometriosis awareness. We must be in the front line of removing associated stigma and also misinformation about endometriosis. And lastly, we need to tell people to come out. We need to inform all the stakeholders. I'm talking about media. I'm talking about politicians. Politician needs to be informed, because at the end of the day, the policy, if we have an endometriosis policy, then it's going to assist our patients to have a subsidized price for endometriosis treatment. So that's what I can say. And last but not least, I invite you once again for endometriosis conference, which will take place in Nairobi in July. And as my colleague said, we need to speak together as a continent. And I invite you to the Pan-African Endometriosis Society, which is being launched in Cairo in September. So feel free, feel welcome, and let us all work together for the betterment of endometriosis management in the continent and also in the region. Thank you very much.
Thank you very much, Dr. Ezekiel Macha from the University of Nairobi, for that. Elaborate input and being able to share with us as a continent and that is there, and to know that there is raise awareness, endometriosis, but also on our side all of one being able to diagnose endometriosis rightly, those who need surgery and those who need medical intervention. Yes, thank you again. We're very honored to have you around. There are some questions that have come through I see one of the concerns coming through is a CPD link. We will discuss as a last one, see how to work on that. Yes, Mr. Jerome ably answered one of the questions concerning ultrasound versus MRI. And like that will not go through again, but the take-home message is that ultrasound is currently a gold standard for diagnosis of endometriosis, really in the right hands, and with training, it's the gold standard. Yes, there was a question from Dr. Sematimba concerning have I forgotten the question? How do you place the two? Yes, Dr. Spire, please go ahead.
Thank you very much, Dr. Mugisa, and I want to thank Dr. Mecha. Dr. Mecha is a very passionate man in endometriosis, and I really want to take this opportunity to thank him for spearheading the fight of endometriosis in East Africa and Africa at large. He has done a lot of research, put together a number of papers. He's still doing a lot of research looking at other markers we can use to diagnose endometriosis other than ultrasound. So he has organized a number of conferences, a number of lectures, and him, together with our colleagues in Kenya, have really done a lot to train our counterparts here in Uganda and in Africa, so that we can spearhead the fight against endometriosis, just like other European countries are. So, Dr. Mecha, I want to thank you for that. We shall continue to work with you to make sure that we battle this monster of endometriosis. And I want to say to you that we shall always be there with you in all you're trying to organize, so that we make the fight together. And as you said, yes, and as you said, we are going to take it on to involve the entire Africa. As you said, together with other colleagues from Ethiopia, South Africa, Morocco, Nigeria, we are trying to come up with a Pan-African Endometriosis Society. And we think that if we put our hands together as Africans, we can start understanding the burden of disease in our midst. So colleagues, feel free to be members of that society, which we are going to launch in September in Cairo. Going back to the question, I'll share the content again and try to run that slide again for Dr. Sematimba and the others. He asked about the sliding sign. The sliding sign, as we said, is basically helpful to know whether the uterus is stuck or mobile. It helps us to see whether the porch of Douglas is free, whether the uterus is held onto the bladder anteriorly or the rectum posteriorly. And I'll run this video again. You can see that the probe is usually in the anterior fornix. The probe is in anterior fornix, and you are pushing first initially the uterus gently down to see if it slides with the bladder. Then you put the probe in the posterior fornix to try and see if the uterus slides off the rectum. So that is how it looks like. You can see the probe, the cervix is here, the probe is slightly in anterior vaginal fornix, and with that gentle pressing down, you'll be able to tell that the uterus slides freely anteriorly and posteriorly. And here you're able to show that both the uterus and vagina and the rectum move together. So basically it gives you a clue of whether you have a free POD or a stuck POD. I don't know whether that makes it clear for you, Dr. Sematimba.
Yes, it does. It's very clear. Thank you. Then about the junctional zone.
The junctional zone, of course, this is just one form of the way Musa's criteria looks at adenomyosis. You know, adenomyosis is one of the things that is difficult to diagnose. We must appreciate it takes an eye that has looked at several lesions over time. Apart from just looking at the obvious discrepancy of the size of the uterus, Sometimes patients have a normal sized uterus, and I think my colleagues, Pius and Sally, can testify that most of the time when we're doing these scans at our facility, you find patients who have very bad dysmenorrhea. But when you look at the uterus, you see the uterus is normal size, and you can easily pass them as normal. But when you start looking closely, using the Mosas criteria, you start to realize that they have small infarcts, small cystic areas in the myometrium, and sometimes the distinction between the endometrium and the myometrium, what you call the junctional zone, has haziness, has several lesions. With ultrasound, you can pick up these lesions, but it is also known that MRI would be a better way of looking at the junctional zone. Also, literature talks about a 3D scan. If you're not sure, you can always use a 3D scan or MRI to pick out these lesions of endometriosis in detail. But with a good endometriosis eye, you should be able to see these lesions of endometriosis rather than adenomyosis.
Also to add on, measuring the size of the junctional zone is also helpful. When you get a thicker junctional zone, which is greater than 12 millimeters, it also tells you that there's something happening there. So it is also a good habit to measure the junctional zone thickness.
Okay. Also, perhaps I want to also add on that usually on a junction zone, we usually see endometrial buds that invade the myometrium. Usually the endometrium can be regular. Sometimes the margins are not well defined for the endometrium, either anteriorly or posteriorly. And another thing that you see some cysts that are in the junction zone. So it's a very good criteria, and you should observe clearly to see that. Thank you very much.
Yeah, thank you, Pius, for that. Though we have to be sometimes careful when the patient has had previous surgery, for example, myomectomy or a cesarean section, sometimes scarring around the junctional zone might confuse you, but yes, as they put it, that's how we assess the junctional zone. I saw some other questions in the chat. Dr. Mugisa, I thought I should also point a little bit about them.
Yes, there were some questions. Yes, you can go ahead and answer. I see a few hands up.
I think it was a patient. She asked that how much pain should you have to be able to diagnose endometriosis? In my first disclaimer, I think I said that there is no pain that should be ignored for endometriosis. But to quantify it, I would say that any pain that is significant enough to affect quality of life, and quality of life basically will mean if a woman stops doing the usual chores, if the young ladies and they cannot go to school, they spend more time in bed, they cannot enjoy life, they cannot smile during menses, then it is most likely not normal. So in other words, we should be very careful to draw a line between what is normal and what is normal. Any persistent pain that is severe enough to affect quality of life should really be looked at. And then someone else talked about scar endometriosis. I didn't get that question very well, but if I have to extrapolate, maybe I would say that if you have a scar and it is painful cyclically, what we call catamenial, if you have a scar which reacts in a cyclic manner, that during the period of menses, you get scar pain, or do you have bleeding around the scar like the umbilicus or any swelling, then it is most likely to be an endometriosis lesion, and it has to be looked at. Of course, lastly, someone asked ultrasound versus laparoscopy, and you're happy to know that ultrasound sees better than laparoscopy. Yes, ultrasound has a better depth of perception compared to laparoscopy, and we should use it as a gold standard, as we said, to assess for lesions before someone plans laparoscopy. Laparoscopy should be planned as a mode of treatment. When someone has properly seen your disease, staged your disease, understood the nature of lesions, and given you a harsh NZN classification, is when we should talk about surgical treatment versus medical treatment. And if it is surgical treatment, it has to be clear. What interventions are you going to have? What is the benefit of having surgery versus medical treatment? What are the fertility challenges? You know, you have to go through all that kind of conversation before organizing for surgery. I think these are the questions that I saw in the box. Back to you, Dr. Please.
Yes, yes. Thank you, Dr. Spire. Yes, those were the questions. There's probably one that has just come in. Is it possible to elicit sliding sign on a digital rectal exam? I think yes, you can. You can be able to, well, the sliding sign in this case is on the TVS, but you can actually, with a good bimania, you can be able to elicit some form of to feel whether your uterus is free or adherent on the lateral pelvic wall or adherent posteriorly. So yeah, I think that can be. But I don't know, Spire, Dr. Spire, please add something to that if you can. Is it possible to elicit sliding sign on a digital rectal exam?
I would say that a digital rectal exam, yes, would give you a clue on whether the posterior uterosacral ligaments are involved, on whether the cervix moves well with the vagina. But ideally, it is a little uncomfortable to have the finger behind someone's rectum, as we all know, and it will not give you so much of the information, because we know that it is not just the sliding sign you need for the rectum. You really need to look out for lesions in the bowel. That is more important. You need to look out for lesions in the anterior wall of the rectum. So that's why you need a TVS, because when you do a TVS, you can pick out the lesions at the thorax, the uterosacrals, and you're able to see everything slide or not, and you're able to pick out these nodules in the anterior rectum. So it is better to combine both digital exam plus ultrasound.
Yes, thank you very much. I see a hand from Dr. June Tibaleka. You have a question? And,
yes, I do.
Yes, Dr.
Yes,
June.
actually a comment.
Yes.
I just wanted to point out the limitations of ultrasound. This presentation has been really great in terms of, showing us how the utility of ultrasound in endometriosis, but, not all ultrasound machines are created equal, right? So the newer generation ones have better images, like the images in the presentation have been fantastic and so clear, but many of our machines do not have that resolution. That's one thing. The second thing is, ultrasound is highly operator dependent, right? If you don't do ultrasound frequently, you will likely miss a lot of lesions. And yes, we've had a really good summary right now in this presentation on what to look for. But if you don't use it regularly, we're going to miss these lesions, which brings me to another point. Is there a training that's going to be set up for, people in gynecology to, get this done? Because it's one thing to do this every day and be comfortable with it. That's when I think it would be called a gold standard. But for many of us who don't do this regularly, ultrasounds in our hands are not the gold standard.
Thank you very much, Dr. June. You've raised a very, very important, aspect. One, having an exposure of the fact that with ultrasound in the trained hands, it's able to give you all this detailed information. It like triggers in us a need to train, a need for us to get better. And yes, we are looking for any possible opportunity to have trainings even come right here in our locally setting in Uganda. And that's why we're having collaborations, trying to get collaborations with you know, the Kenyan Society of Endometriosis, the African Endometriosis League, the European Endometriosis League, to support us, because these in these areas they've already had some right steps in, have taken some good steps in the right direction to train, to sensitize, and to get people better, even as gynecologists. I looked at a surgery log for one of the persons who trained, who I happen to have met in a training, and they had done about 600 plus endometriosis surgery in 1 year. And that's in their hospital. And I can imagine, you can imagine how many scans they had done for those patients. So with this, we are being challenged to seek for training, to seek to get better. And yes, we are working towards seeing how we can get everyone on board to help us get better, to grow together and get better, and be at that point where, you know, what you can see as a gynecologist is what I could be able to see, is what someone in Uganda will see, is what someone in Imbarara will see, because we've had the same training. We are having a uniform reporting tool, and that helps us to be able to do the same thing across. But yes, there's a big gap. Honestly, there's a big gap. We not just us as gynecologists, but even on the side of the radiology, to be able to pick these things in detail. Most times the report you'll get will tell you endometrioma, but will not give you all this detail in the anterior compartment, posterior compartment, in the rectal space, vaginal spaces. So yes, there is a big challenge for us. Like someone said, there's always the biggest room available is for us to get better. So thank you. I see another hand from Smart 6 Infinix. I don't know.
Yeah, so I also wanted to add on that. When you get radiographers on board.
This is Pius, right?
Yes, this is Pius.
Pius Kajumba. All right. Yes, Pius.
Yes, I was saying that if we had the radiographers on board and they get to know when the gynes are specific on their requisitions for an endo scan, I think it would be better. The sonographers they are skilled in hands with these machines and how to evaluate. So if the gynes get these sonographers on board, I think it will make a very big difference, because they have a skill and they have a big hands-on with the probes. So you get your radiographer on board so that he does not only do just a routine TVS, but goes out for deep endometriosis. Because when you tell the sonographer to go for a routine transvaginal scan, we'll look for the ovaries and the uterus only, and it will end at that. But you make sure that you tell your radiographer or sonographer to look at the posterior and anterior compartment, and this will help us to better diagnose this, because it's about the relations that we have between the sonographer and the gynes. Thank you.
Thank you, Pius, for that comment. Yes.
Just a little addition.
Yes.
Yes, Dr. Mugisa. I want to thank the comments about, you can see a glaring need for learning. The reason we had this CME was to trigger and to stimulate everyone in their comfort zones to try and start thinking endo, try to develop an endo eye in whatever you do, whether it is taking a history, clinic examination of your patient, and ultimately develop the skill of the endo eye on ultrasound. This is what we're trying to do, stimulate everyone so that they can start learning. It is a journey, but it starts with the first step. You must have the correct attitude to change your practice. and then you can always learn. One of the tricks is start scanning. I've seen, for example, many gynecologists do not want to learn to do a TVS. A TVS in the hand of a gynecologist should be a very excellent tool of diagnosis because they have taken the history, they have examined, they know the patient. Sometimes they send the patient to the scan room and get a report which says contrary to what they're expecting. And then they take the report. So it starts by the gynecologist walking into the scan room, getting conversant who's doing a normal vaginal scan. It's not rocket science. It's not very difficult to do a TVS. A TVS is supposed to be an office procedure, which takes about 5 minutes to 15 minutes. So if you routinely first do a normal vaginal scan and look out for all the anatomical landmarks, it will be very easy for you to start seeing the endometriosis lesions. At our facility, we are trying to start a program where we shall train people who are interested in endometriosis, because we run an endometriosis clinic every Thursday, and we get a sizable number of women who have these lesions. At least we see about 5 to 10 lesions on average. And if you see these lesions now and then, and you run a systematic idea criteria on these women, you have a checklist. It becomes a routine on you that every other scan you do, you will feel like you want to go through the same routine. So it starts from there. We are open to teach anyone who wants to come along and get these skills of doing an endo ultrasound. Then over time, we know that these skills will spill over with a multiplier effect in many centers. We want as many radiographers to come on board, radiologists, and many who don't have an endo eye. Even when they do an MRI, I've seen MRIs that come out and say negative. There is no endo. And you go and put in a scope and find something different. So it takes someone with an endo eye with a bit of experience to be able to pick up this scan. And the journey has to start now. And we know that if we're interested and we have more of these seminars, we can always make a difference. Thank you.
Yes, thank you very much, Dr. Spire. I see another hand, Dr. Saka. Briefly, that should be the last, and then maybe we close, we wrap it up. Dr. Saka, is that your hand up? Okay, maybe there is no comment. So, colleagues, we thank you. First of all, I would want, on behalf of Association of Laparoscopic Surgeons of Uganda, who have arranged this webinar, to thank each one of you for making time off your Friday evening. You probably could have been somewhere else, but you've chosen to hang around for the last 1 hour. So we don't take that for granted. We thank you so much. That speaks a lot to know that there is a need for us to learn and to grow together. We are all on this journey of learning. Some of us have been stimulated maybe a little earlier than others, but we say we need to work together and grow together and help each other get better, especially to manage this monster of endometriosis. So I guess this is a step in the right direction. And who knows what will come through, more trainings, more CMEs for us to get better. So thank you so much, each one of you. Unless there's any other comments, I would like us to wrap it up and end here.
Maybe before you leave, yes. I just wanted to say that next month, the month of March, is an endo month. It is the world is celebrating endometriosis awareness. And because of that, we have organized a small camp where we are going to offer free screening for all women with chronic pelvic pain and those with menstrual problems. So if you have any woman out there or sister who would complains or has any of these signs, bring them in the second week of March. We shall be grateful to bring them for endometriosis. as our contribution to the awareness. Thank you very much.
Okay,
I want to
thank
thank
you
everyone for attending. Thanks for giving us an opportunity to present to you.
Yes, absolutely. Yes, thank you. Again, I think, I don't know how we shall do it, but there are lots of comments on CPD points and increase on the logging numbers, because some people missed because the cut limit was 100 people. But I get a sense of that we may need to maybe repeat the CME, not, from what I hear, but let's sit down and reevaluate and see. We surely will not hesitate to share any knowledge or to reshare any experience or knowledge. So thank you again. Yes, there was a recording in session, so maybe we shall be able to share the recording.
Sure.
Thank you very much.
Bye,
and a
everyone.
very, very good night to everyone. Thank
Bye.
you.
Good night.
God bless you all.
Bye.